All right, so what I'd like to do today is give you a two-part message. One is about sickle cell disease and another about sickle trait. And the focus is on what's new, because sickle cell disease actually is an old disease. It's been around for thousands and thousands of years, but it was described in the Western medical literature just about 100 years ago. So this is a milestone year for sickle cell disease. And so these are some of the things that are sort of updates compared to what you might have seen during residency or just in the past few years. So the first, for the DC area, what's new in sickle cell disease is that there's greater ethnic diversity than ever before. That newborn screening is something that can capture most diagnoses of sickle cell disease, but you're going to see that there's immigrants from many other states, many other countries who have sickle cell disease. The other way, the ways you can think about this is that there's migration of people from all different places, but particularly from around the old world areas where there used to be malaria. And malaria is something that's a big, huge evolutionary pressure that if malaria is sweeping through your village, the people with sickle trait would tend to survive better. And so there's a superior factor, a strengthening gene. And then the people who come from these malaria areas, sub-Saharan Africa, around the Middle East, around the Mediterranean, including over at Italy and stuff like that, and over into India and the Persian Gulf. These are all people who are migrating all over the place, including into the DC area. And so it's very possible to have a blonde-haired, blue-eyed child who has sickle cell. And this is a picture of one of my patients eating her healthy snacks. And she has sickle cell. She's in Southern Maryland. She always has to persuade people that she really has sickle cell disease. And this is the reason that all newborns are screened at birth for sickle hemoglobin. It is possible to miss your newborn screening. Either there was a clerical error, or you went straight to the newborn ICU and nobody stopped to actually do the heel stick, or you got transfused, or something else happened like that. But right now, it's really a myth that only African Americans get sickle cell disease. The distribution of patients right now we're seeing at Children's National Medical Center with sickle cell, about 2/3 are African American, but about 1/3 African immigrants, either born here of African parents, immigrant parents, or immigrants themselves. We're seeing about 3% Hispanic patients and 7% other. And sometimes the other is very, very interesting to see. We have one patient whose mother is from like Venezuela and father is from Croatia, and has sickle cell. So you can have all kinds of different national origins, and if you're seeing somebody coming from any place, practically any place in the world, you can think about whether they have had sickle cell testing. So another new thing in sickle cell is more cures by transplantation. And so the message here is going to be watching for siblings. Bone marrow transplantation is something that can cure sickle cell disease. The latest data in the 2000s is that there's about a 96% survival for sickle cell bone marrow transplants, and it's about a 93% cure of their sickle cell disease. So this is about as good as transplant gets compared to transplant for leukemia, transplant for other conditions. Sickle cell or aplastic anemia are probably the ones that have the very best outcomes for transplant. And this is with an HLA-matched sibling. So if you have an HLA-matched sibling and need to have a bone marrow transplant, that's actually covered by insurance. You can persuade the insurance company, persuade Medicare. This is really cost-effective. Over the lifetime of the child, you'll save money, as well as saving pain and suffering. And what we also have now as new information is that long-term follow-up is looking better and better. So not only do you go through and you get a cure, but you're not real damaged afterwards. And the CNS, things having to do with stroke, would either stabilize or maybe possibly get a little bit worse, but usually they stabilize and don't get any worse. Pain is gone. The lungs are stable or improved, and engraftment can be stable for as long as we've been following them. There is, however, the chance of graft rejection, and if it's going to happen, it's going to happen early. So we don't tend to see late graft rejection. And the one thing that's showing up now, which was suspected before, is that there is gonadal toxicity. So if you have a bone marrow transplant, you have, depending on whether you're male or female and what age you were at the time of the transplant, you have more than 50% chance of fertility problems. If you think about it, though, the gonads And the germline for these patients is still sickle cell. They still have SS in their germline. So reproduction may not be the very best thing in terms of just genetics. So some of these actually have had pregnancies and gone through, but they do have to still think about who their mate is. And then the other new thing that you may have seen in the news just about half a year ago is that the NIH, just around the corner here, has been very successful with adult sickle cell bone marrow transplant. So they've had 10 adults reported in this study in the New England Journal of Medicine, and then through the media, adults from 16 to 45 years of age with severe sickle cell disease with an HLA matched sibling donor. And what they got was 9 out of 10 had long-term stable donor engraftment, none died, and they have not had graft versus host disease or other problems. The approach that they took for these adults was the so-called reduced intensity approach. And so that is taking more of an immunomodulation. So instead of doing it like a bone marrow transplant where you're trying to wipe out all the bone marrow, you're actually just trying to damp down the immune system so that the body will accept the graft. And this is completely the same as doing a kidney transplant, doing a solid organ transplant. So the folks at NIH have just basically kept these patients on sirolimus, immunosuppression long term, and have not taken anybody off of that. And they're hoping that they'll continue to see the stable engraftment with a mixture of the donor and the host. And what's the relevance of bone marrow transplant for somebody who's a primary care doctor? Well, the basic idea is that you need to have a sibling for most of these transplants. You have to have some kind of donor, and a sibling is the best one. So if you are seeing a child with sickle cell disease and you walk in and the mom is pregnant, then you can say, oh, this may be a donor. And you can ask first whether this is a full sibling, and you can suggest cord blood harvest, so that there's this program, federally funded, or it's a federal private partnership called the Sibling Connection Program. And here's the website for it, and here's the phone number. That'll actually give you free storage of that cord blood for 5 years. And this is compared to the regular, not in this program type of storage, which would probably be $10,000, $12,000. The reason they're doing this is to expand the number of bone marrow transplants, and so this is with federal funding, but being run by a private company. The next thing new in sickle cell disease is we're learning more and more that hydroxyurea is quite helpful. And so basically think about hydroxyurea in terms of benefits and risks. So this little scale here is supposed to be the benefits on the right-hand side of the screen, your left, yeah, and then the risks on the other side. But what the scale is doing is tipping more toward the benefits. And so hydroxyurea is FDA approved for adults with sickle cell. It's been tested pretty extensively in teenagers for about 15 years now. And then there's going to be new information coming out in the next few months about babies down to age 9 months. And the results are pretty much all the same, that you have reduced frequency of acute complications, you reduce the hemolysis, and make the hemoglobin rise a little bit. It also improves life expectancy, and very notably can reduce absences from school or work. So that there's some young adults with sickle cell who'll tell me, you know, the reason that I've managed to become a lawyer, I've gotten my MBA, I'm running a small business or whatever else, is because of hydroxyurea. That without this, I wouldn't be able to get through the major tests. I would be missing so much school, I'd flunk out, or I'd not be able to keep up work. And cognitive function is also a factor there. On the downside is that this is not a cure. It's just making things more mild. That it's inconvenient because it's a daily medicine. And then people have been worried about teratogenicity. Hydroxyurea actually is one of the classic animal models for birth defects, but the teratogenicity has not been seen in humans. We warn people up, down, and sideways that they should not get pregnant, they should not father children while on hydroxyurea. Some people did it anyway, and so there have been 14 cases of pregnancies while on hydroxyurea and no birth defects. There were some miscarriages, but no birth defects. What it does, however, is it can impair sperm motility a little bit and sperm counts, but that's mostly reversible. So overall, like I said, the hydroxyurea risks and benefits seem to be tipping in the favor of benefit, and there was a consensus document just about a year and a half ago from NIH by experts not in the field of sickle cell, but experts in sort of risk management. And they looked at the whole data and they said, yeah, this looks pretty good. You really should be using it more. So increasingly, you're going to see sickle cell patients on hydroxyurea. The mechanisms of action of this lovely drug are unknown, however. So we have three possible things that it might help with: reducing the cellularity of the marrow, making the marrow strain a little bit to make the red cells, increasing the fetal hemoglobin, which is the middle panel there, so that there's less polymerization, and then also reducing adherence, reducing the stickiness of the cells. But which one of these is the dominant thing, we're not really sure, but we give this medicine and it really seems to help. And then the next new thing is that there's actually more treatments and more research going on now than before, so that people with sickle cell have a lot more hope. And one of the things we're trying to do is do early interventions in this condition of acute chest syndrome. So acute chest syndrome is like pneumonia, but you start off with an infiltrate on the chest x-ray, and then it can amplify fairly quickly with sickling going on at the edges of that infiltrate, and then you have more inflammation, more hypoxia, more sickling, and it just spirals downward. But many people just start off with, kids will start off with mild acute chest and never get more severe, and so we're going to try to keep them from getting more severe at all. This also means that there is no such thing as pneumonia without being called acute chest syndrome. And this is something that can have such high morbidity that if you have more than 2 acute chest syndrome, it's one of the eligibility criteria for a transplant. We've been able to decrease acute chest syndrome, excuse me, decrease acute chest syndrome rates at Children's National in the hospitalized patients, so you can see the overall bars are going down there. We're also trying to address asthma, and my colleague, Dr. Comborlis, who's going to come next, I don't know if he's going to talk about sickle cell at all, but he's a sickle cell expert as well as a pulmonary expert. We're going to have more and more patients seeing both the pulmonologist and the hematologist, because asthma really seems to make a difference in worsening your sickle cell care. There's a caveat here for the primary care docs that if you put a child on pulse steroids for their asthma and they have sickle cell, there's this phenomenon of rebound pain after a pulse dose, that if you give them just like a few days of steroids and then stop, then very often, 48 hours later, they have this roaring sickle cell pain, and they might need to get admitted or go to the emergency room. But if you give the pulse and then you kind of taper it, and it could be a linear or exponential taper, whatever you want, taper it over a few days, that really seems to avoid that problem and avoids the readmissions. The other thing we do for prevention is there's Prevnar 13 that's now out. People have that in their offices now? Yeah? That's great. We don't have it in our clinic. It's recommended as a booster for those who are immunodeficient, and this does include sickle cell patients, with a recommendation apparently for boosters somewhere before 6 years of age. If you feel like giving it afterwards, to me that's fine, but particularly if you have somebody who's under 6 and hasn't gotten one yet, go ahead and sneak that in there. And then we continue to give the Pneumovax, the unconjugated vaccine, which is highly preventive. And with all this, this is what the Kaplan-Meier survival curves over time have done. They've gone up. So that, as you know, Kaplan-Meier survival curve, the closer you are to 100% survival over time, the better. And so starting from the 70s with these curves down here, and then into the 80s, and this is the same in Jamaica or in the US, the survival for children has gotten better and better, so that in the 2000s, really there's been hardly any children who die. And this is in marked contrast to when you had all these 2-year-olds, 3-year-olds dying of sepsis. And I think this is mostly thanks to the Prevnar, Pneumovax, and fever management. So with this, now we have adolescents, and we have adults, and we even have geriatric patients with sickle cell. And so we have to think more about adolescent transition. We have to think more about taking care of adults and having adult hematologists who are willing to take care of sickle cell. And one of the things we're trying to do for the adolescent transition is a program that will include focus groups with feedback from the adults, peer small group discussions, tutoring, mentoring, kind of big brother program, and then also computer-based modules, so that up on the internet you can go and click through things about sickle cell, know your own disease, or sickle cell, know about your insurance options or about your job options, or click on something and hear an adult talking for 2 minutes about their sickle cell experience. It's still in the works. We don't have it quite yet. And the research pipeline now has more candidate drugs than ever before. So it used to be that we would get one anti-sickling clinical trial every 2 years or something like that. Now I have to worry about competing studies, that there could actually be 5 studies going on at the same time for the same kind of patients. Some of these are nutritional supplements that have very low toxicity, might have low benefit, but they have very low toxicity, and they include things like antioxidants, fish oil, stuff like that. And then sometimes there's acute treatments which will include magnesium, magnesium infusion. All right, so now we're going to shift gears over to sickle trait. So has anybody heard in the news about the NCAA wanting to test Division I athletes? Yeah, okay, so this is what we're going to talk about here. That there's been all these news reports, starting from about a little over a year ago, that rare athlete deaths will spur sickle cell trait testing, and the NCAA finally addressed the leading cause of death and all this stuff like that, and it's everywhere, New York Times and all that. And the reason for this is lawsuit, that the NCAA lost a lawsuit. There was an athlete, a football player at Rice University who died with sickle trait during a conditioning workout in the early part of football season in 2006. And so his family sued the NCAA, and part of their settlement was to say that they would enhance awareness of sickle cell and change what is done so that people wouldn't die with sickle trait complications. So they made this big old announcement, and it's a mess. I have to say, it's just plain a mess. So right now, they're going to say that for the next school year, 2010 to 2011 academic year, all athletes in Division I must be showing proof of a previous test or get newly tested for sickle trait or sign a waiver. And the reason they say they want to do this is to cut down on deaths with sickle trait and conditioning. And this is going to be in basically any of your college students who are coming to you. So what are they talking about? This is not my area of expertise, but this is the general picture, is that if you have exercise in hot, humid conditions, which we have so much in DC, you can have all these different problems when you overdo it. You can get heat exhaustion, you can get heat injury, you can go into shock, renal failure, heat stroke. And all of these pathophysiologies are involved, but it seemed that people with sickle trait were a little bit more frequently encountered among those who are dying of these problems. And who dies of these problems? It's basically the people who are pushing their physical exertion to really extreme levels. So that's the military and athletes. So one comparison table looked at the military and the athletes, tried to look at cause or etiologies if you have somebody who died while exercising. And you can kind of see the breakdown here that many of them were explained, that you can have either a cardiac reason or a non-cardiac reason, but you can explain it, like they have asthma or they have incredibly obese or poorly conditioned or something like that. And then some of them are called idiopathic, some of them are called just from the heat, and then some are labeled as being from sickle trait. And you look at the percentages down here, and you can see what a huge problem this is for the NCAA, 0.2%. But this is what the lawsuit was about, so this is what they're going to do something for. And then in contrast, the military, this is in the 90s. Oh my goodness. All right. The military wanted to address this first because they were actually having more problems with military recruits dying during training. So they looked at their data over several decades, and they measured their denominators are huge, in the tens of thousands. And they saw how many unexplained exercise-related deaths there were among those with sickle trait versus no sickle trait, and they figured out odds ratios, and they saw that it was there. There was a relative risk of 30, and it was highly statistically significant, 10 to the minus 6. But that's statistically significant with very small numbers. Was this 18 recruits over the course of 4 or 5 years or something like that? So they tried to put in an intervention to see if they could reduce exercise-related deaths, especially in recruits with sickle trait. And they put this in place in grand military fashion, just sort of, boom, we're going to do this. I don't know if they asked anybody's permission or signed consent. So starting from before the intervention, which was in the early, 81, they looked at those death rates, and that was kind of what you were looking at before. And then they did this intervention in half of their recruit training places. So the Marine Corps facility in Paris Island, and then Army and Air Force were participating in the intervention part, and then another Marine Corps place at San Diego, and then the Navy did not participate. And so that was the comparison group, with 1 million or so in each arm. That's a huge study. And they also instituted this thing called the wet bulb globe temperature index, which is kind of like a heat index, but it also accounts for how much solar radiation there is, how hot it's being just from the sun baking your absorbent surfaces. And they put in this, this flag system where, depending on how high that number is, the wet bulb globe temperature index was, the military base will fly a flag that's either green, yellow, red, or black. And if you're at the higher levels, you're supposed to curtail your activity, wear your tropical type uniform, and adjust what you do. And if it's in the green or the no flag, then you don't have to worry about that. And with that, the intervention was to have your drill instructor record this temperature, change your exercise intensity, order you to take water and observe your water consumption, and then also modify what kind of clothing they wear. And then further, the drill instructor is supposed to immediately take a rectal temperature, cool and rehydrate you if you faint, if you fall out. And they did this. And they also did, when there was an actual death, they investigated heavily, and they acknowledged that sometimes if you have an arrhythmia, you can't tell at autopsy because there's no physical trace anymore. I don't know if this projects well. Well, okay. The outcome here, the upper three rows is the participating ones, the ones where the drill instructors were paying attention to the temperature and the wet bulb globe index. And they had so many predicted deaths among those with sickle trait and so many with hemoglobin A, normal hemoglobin. And this is what they actually observed, was no deaths in those with sickle trait, none. And so they considered this difference between the predicted and the observed to be lives saved. Then they also looked at the predicted versus the deaths among those without sickle trait. And you actually see there's some with no sickle trait that died. And there's also lives saved here. And then those with no participation had a certain number of observed and a certain number predicted. And there was no difference really between the predicted and the observed. And they figured there's no lives saved by not having an intervention. And their conclusion was that if you make an intervention, this is the underlined part here, if you make an intervention, that you can eliminate the excess death from sickle trait. So this is the military actually figured out how to do this, and that was, in the 80s. So they figured out how to prevent it by doing this flag system and by getting their very enthusiastic drill instructors to just modify what they do. So you would think that the sports world could do the same kind of thing. So right now we're still trying to persuade the sports world to do that. And the person who did these studies is concluding that with proper precautions, virtually nobody would have to die a sudden death because they have sickle trait, including athletes as well as the military recruits. So let me see, how are we doing on time?
You're doing well. You've got 14 minutes.
Okay.
Well, actually, you've got a little less than that. Let's say you have 12 minutes.
Okay. So the additional advice to the military members with sickle trait, which would also extend to those who are athletes, is that there is this greater risk of a fatal heat exertional illness and death. And this is particularly high if you go into your football training or your military basic boot camp poorly conditioned, or if you're dehydrated or you're obese or you're sleep deprived or you're doing this at high altitude, or if you're dressing in some kind of heavy clothing, or if you're making heroic efforts. And heroic efforts is something that the military and also football coaches will encourage you to do, is like leave it all on the field and all this kind of stuff. But if you remember, heroic efforts is something that really can still kill people. And the marathon is something that lots of people do all the time to challenge themselves. But the very first marathon, what happened to that marathoner? He died. So, these are things that are pushing you to the limits of human endurance. And if you go into it without being smart, then you have a much more chance of a fatal outcome. So is this high risk? There is this high risk for sickle trait, but you can largely eliminate it if you're smart. And so you can improve your ability to sweat by having water and limiting your exercise and dressing yourself right. And then if there is something where you're starting to have problems, then you should stop and treat the mild signs and stuff like that before it gets to heat stroke. Let's see, we'll skip that part. And then the conclusion from the military is that, well, with all this that we put in place, where we did the same intervention whether you had sickle trait or not, does it really make sense to screen for sickle trait? And the military kind of concluded that it doesn't make that much sense, that the one thing they were doing to help with sickle trait really helped for everybody, so they would institute it for everybody. And the only thing that would be helpful is to make the people with sickle trait train smarter, and also to catch the rare person who actually comes in with sickle cell disease, unrecognized sickle cell disease. Now, there are many different types of sickle cell disease, and so it's possible to get through high school, and then if you lie, don't tell the military that you have sickle cell disease, you could actually get in. And I met a gentleman who did that, but he managed to get through basic training and then was kind of sick afterwards, and he stayed in the military just long enough to get an honorable discharge, and so he's a veteran now, and he gets veterans benefits even though he has sickle cell disease. But he had sickle beta plus thalassemia. So that overall the military has decided not to do much more emphasis on screening, and they're taking quite a different approach than what the NCAA is doing. So the advice to give to your sickle cell trait patients, but basically everybody, is to prevent yourself from having sudden collapse. So start your conditioning gradually. Don't go crazy with your very first attempt at exercise. Avoid exercising in high temperatures. Hydrate yourself. I got my water here. And what the military would do is they'd say you really need to drink whether you're thirsty or not. You just need to plan to drink. And what I'm told is that what the drill instructors will sometimes do, especially on like desert survival training, is they'll order their platoon to turn around, pee in a cup, show them the cup, and see how dark the urine is. And if the urine's too dark, soldier, you got to drink some more, and then you pee again or something like that. So they really promote hydration. Repeated high temperature exposure apparently is a risk that if you got overheated yesterday, you have a higher chance of having fatal problems if you continue to do this exercise, because your body already took a hit. And then wearing lighter clothing to help dissipate body heat. So overall, the summary is that what's new in sickle cell disease and sickle trait is a bunch of different things for sickle cell disease, including greater ethnic diversity, more education, more transplants, a sibling cord blood program for free, more hydroxyurea usage and benefits, and more treatments, both now and also in the pipeline. And then with sickle trait, there is this new thing from the NCAA where the NCAA wants genetic testing by the athletic departments. And did I mention who is going to do the genetic counseling for these patients? It's either nobody or else the coach or the trainer, who is probably not well equipped to do genetic counseling. So we're just waiting for the first counter lawsuit to occur. And we propose that the sports world should really try to improve all their conditioning programs and take a page from what the military has been doing. We think long-term prevention is better than treating complications. This is something that's, a basic tenet of pediatrics as we try to do prevention. And we have many, many websites where we're starting to put some of this information. So even if you didn't get it here, you can surf through places like sicklecellinformation.org or the Children's National website. There's also websites with entertaining things, and we're going to try to put up more games and stuff like that in the future. Questions? Any questions? So the question is whether there was an autopsy and whether he had sickle cells. So the answer is that yes, there was an autopsy, but seeing sickle cells doesn't matter that much, or doesn't mean that much, because if you take a sickle trait red cell and subject it to the right conditions in vitro, it can still sickle, but it may not be what was happening in the person. And for instance, there's agonal hypoxia and ischemia, which could cause problems. And then, I think this is reasonably well established, is that if you put the right formaldehyde conditions, that actually can cause sickling too. So many of the things that you would make you see sickled cells doesn't necessarily mean that it happened while the person was still alive. It could have been a post-mortem problem. Yes. Yep.
Got a 15-year-old with sickle cell disease, does not have a sibling. He lives just with his mom, and he's been to see you guys for quite a while. He gets sick quite often, does not have acute chest syndrome. We had talked about transplantation. His frequency is high, and the intensity, despite being on hydroxyurea, is pretty significant. Any hope for these kind of individuals?
Certainly there's hope. Right now, besides hydroxyurea, we're hoping that there will be additional combination treatments, either with these nutritional supplements or with some other pharmacologic agent. And then the other thing is that as we get better with transplant, unrelated donor transplant will become much more feasible and safe. Right now, they're still trying to solve the problems of graft rejection and also graft versus host disease for unrelated donors. And so the ones going for unrelated donor transplant are those who've had stroke with sickle cell, where your outlook is very clearly worse than somebody else who's living with sickle cell but with pain. So right now we have had there's an unrelated donor protocol going on, which has had about a dozen patients on it in the one that we're participating in, and there's others going on too. And these have had moderately good results, so that over the next few years, maybe a decade, things should get better. And then, as I said, it used to be that transplant was only available for kids, but now it looks like it can be done for adults too. NIH recently did a transplant for this 65-year-old who said, I know I'm high risk, I know the transplant may kill me, but each day is getting worse, and I might as well just roll the dice. And he had a matched sibling who was willing to donate, so that was different. But he got his transplant, and he left the hospital, and he's doing okay at like 6 weeks out. Yes, sir.
Are you almost convinced or not convinced very much about those studies, from those studies that sickle cell trait patients have this kind of reaction to heat stress or exercise? I mean, these are not, they don't look like the best studies to me.
Right.
But what is your opinion?
Right. I think that, I'm not an exercise expert or anything like that, but if you do push somebody to the extremes of human endurance, then anything that you have is going to tip you over into problems. And so if you're obese, if you're out of shape, then that could be a big risk. And if you have sickle cells that could sickle under some extreme acidosis, hypoxia, and dehydration, then yeah, that could do that.
Would that also relate to flights? You know, you always read that sickle cell patients, if they're at high altitudes, is that a similar circumstance?
Right, related to that. So high altitude exercise, so somebody who was a couch potato most of the year and decides to go to Denver and Pikes Peak to go ski after doing nothing for the last 5 years, they could have a high chance of having problems. And somebody with sickle trait could have problems there too. They can get splenic sequestration up at Denver. But it's also rare. So the Denver's Sickle Cell Center has actually kept records on this, the number of sickle trait patients who have high altitude problems. And it's been like 1 or 2 a year. And compared to the millions of people who have sickle trait, that's really a small
But you think
number.
this is more common, this situation, or hard?
Common, but still a very rare event.
Still rare.
Right, right.
Are there ongoing studies looking at this?
There's a little bit of surveillance, but it's mostly the military. So the military has a denominator of how many total recruits they have. I don't think NCAA or high school athletes have a denominator number. So they'll list the events, but you don't know how many people went by without problems. And I don't know if you saw, but the cardiac is still the leading cause of problems.
The taking of the rectal temperature must have something to do with their reaction, I would say. Wouldn't you think?
Maybe. All right. Thanks very much.